dear audience and distinguished chairs. Let me introduce you in my progress over the last 3 months. My name is Panagiotis Paraskevopoulos, and my vision is to improve palliation of critically ill patients. And for that, my mission is to find the proper idea and implement it properly. I should also thank Balint as my supervisor, Mahmoud as my scientific methodology supervisor, and Daniel as my statistician for the great work. I have 2 projects. One is the addition of antegrade stenting in patients undergoing hepaticogastrostomy for malignant biliary obstruction. And the second one is basically an exercise in prediction model bleeding to predict variceal bleeding. So for my first project, the prevalence of malignant biliary obstruction is approximately 15 to 100,000. And for the irresectable cases, for many decades now, ERCP has been the gold standard, with approximately 500,000 procedures performed annually. And in case of failure, percutaneous biliary drainage is the procedure of choice. But over the last decade, endoscopic ultrasound-guided biliary drainage has emerged as an alternative option. And compared to percutaneous biliary drainage, it offers better outcomes. The thing with endoscopic ultrasound-guided biliary drainage is that mostly it's used in the East, in centers in Japan and in Korea and I don't know what, but not that much in the West yet. So not many people are aware of it. I want to show you what we're trying to do through our PICO. So for P, we have patients with malignant biliary obstruction undergoing hepaticogastrostomy. What is hepaticogastrostomy? Basically, you take an endoscope, you go into the esophagus, into the stomach, and then you use the ultrasound probe because you're going to pierce the stomach and the liver to access the intrahepatic bile duct system. So you don't want to puncture any vessels, so you need the ultrasound. After that, you created the connection. So basically, you have a non-physiological flow of the bile between the intrahepatic bile duct and the stomach. In the antegrade stenting, we do exactly the same thing. We go in, with the endoscope, we go into the stomach, we pierce again the same way, but then we don't create a connection. What we do is we continue with the guide wire until we find the stricture, and then we open it up. And then we place the stent. So you can imagine in that case, the flow of the bile is physiological. But the problem is that when we go out, I made a hole that I never closed. So because the indications for these 2 procedures are similar, somebody thought, why not combining them? So in that way, I have the hepaticogastrostomic track that I can use to place my antegrade stenting. I have 2 routes of drainage. If one fails, the other one picks up. And I'm happy, yes. So we searched in 5 databases. We ended up with 25 articles. This is the risk of bias. It's moderate to severe in some cases, but these are just 4 studies because we're going to have direct and indirect comparisons. So for the technical success, as you can imagine, if I place 1 stent, it would be as easier than placing 2. So this is what our results indicate. We have a tendency for the technical success to be more common when we don't add the antegrade stenting. And this figure is highly related to the second one, the clinical success, which is measured as a decrease in bilirubin by 50%. And we can see here that the odds is approximately 1, which would indicate that since the clinical success is similar and the other procedure is harder to perform, it might be better to just not add the stent. But for that, we need to check our other outcomes also. One is the reintervention rate, which appears quite similar. And the other one is the overall adverse events, that we can see a clear tendency that when we don't add the antegrade stenting, the overall adverse events are more. I don't want to draw any final conclusions because we're still waiting for the time to stent dysfunction and the overall survival. But it seems to me, when I was doing the data extraction and everything, that the overall adverse events are truly less, although probably statistical significance is not reached. And I plan to submit my manuscript by the end of April in these journals. And here where we are with the progress, I have 50% of the plots and the baseline table. And for my second project, of course, clinically, the way that you assess the risk of varices is by endoscopy. You go in with an endoscope, you check the the varices, their morphology, and you designate them as high risk or low risk, so then you can give treatment. I don't expect our model to have a higher sensitivity and specificity than endoscopy, but I think the importance of this project is in the fact that usually in the medical literature, most models are linear regression, which basically means above a certain threshold value, the probability is 100%, below it's 0. And this would lead to many inaccuracies, so the prediction models are not accurate, and there are many other ways that you can build a prediction model. And I just want to give an example why you need to have proper assumptions when you make a prediction model, because without proper assumptions, your prediction model will be inaccurate. The reason is, for example, we expect that in variceal bleeding, the left gastric vein diameter will, of course, increase. But, for example, the portal vein diameter would have to decrease. And this is something you have to take into account when you build your prediction model if you want to be accurate. So this is the summary of my slides, and thank you very much.
Technical question that which is better, a transhepatic a percutaneous procedure or these laparoscopic methods?
It seems
or is there any difference between this percutaneous and the endoscopic methods?
So, for example, in the percutaneous methods, the problem is that there is a lot of pain for the patient because the skin has these nerve fibers that are painful. And if you go inside the organ and you pierce an organ, you won't feel the same pain. So that's one plus. And another plus is that percutaneously, you have many infections because you have basically a drainage. When you go endoscopically, you don't have these problems.
I would like to ask a clarifying question and then a follow-up, probably. So regarding your second project, I wasn't sure whether you're collecting your own data or you work with a given data set.
So the two ways you can do it is either by individual patient data or aggregate data. But we're going to do the non-accurate one, the aggregate data, so we're just going to check in the literature what's available.
Oh, okay. So it's you mean like a meta-analysis type of system or systematic review?
The prediction model will be based on aggregate data, not individual patient data.
But are you actually constructing a prediction model?
Mm-hmm. That's what I would like to do.
Okay. Then, okay, my question is, can you sort of decide what measurements, imaging measurements you include, or is just that given, then that's it?
So if you think the hemodynamics of variceal bleeding, you would have to take into account specific veins and specific things. For example, portal vein diameter, left gastric vein diameter, then the flow, if it's hepatophugal or like the opposite, and stuff like that. Because there's basically a change from the flow towards the liver, away from the liver. So everything else would change. But that doesn't necessarily mean that you can predict accurately the bleeding because of that, of course.
How do you want to validate your model? Once you create your model, how you are going to validate it?
So there are two ways. You can either do, I think basically we're going to do bootstrapping, which is we will take the same data and just tweak it a bit and validate it this way, which is unfortunately the easiest and the least accurate way, but we don't have other ways to work on.